Good afternoon, everybody. My name is Kelly Diak, and I am very excited to be able to present to you this afternoon. To give you a little bit of background on myself, I have spent my entire career in the laboratory, having been in the field for almost 29 years. I am a cytotechnologist by background with my specialty in cytotechnology, and then later achieving my certification in histology. I worked in histology and cytology on the bench for about 10 years, transitioning to the AP supervisor during that time. And then for the last almost 19 years have overseen the anatomic pathology departments for our healthcare system. Our laboratory has 4 main hospitals with a consolidated anatomic pathology department centered at our largest facility. I am likely dating myself, but when I first started, our IHC was all done manually with the plastic humidity chambers that some of you may remember. We laid the slides within the humidity chamber and then filled the bottom up with hot water and placed a cover over it. At that time, we had a test menu of about a dozen or so different antibodies, and a tech spent hours of time preparing and then standing watch over the slides as they incubated. Since then, the art of immunohistochemistry has come such a long way. Now we have multiple automated pieces of equipment with an antibody menu of over 75 assays. Not only has the testing changed significantly since this time, but the standards and regulations have changed as well. So with that in mind, the agenda for the presentation this afternoon will include the following items in relation to immunohistochemistry and quality management in the histology laboratory. We're going to talk through the essential components necessary for your program as related to immunohistochemistry. We will first talk about the definition of specimen types utilized for testing. We will discuss the expectations for instruments and equipment utilized along with general quality control and quality improvement. We'll talk a little bit about the different types of antibody controls. And then our discussion will then take a turn towards test method and antibody validation and verification. And then finally, we'll touch upon the policies and procedures that are required along with the proficiency testing and alternative assessment and result reporting. So the first key element we are going to discuss is the importance of defining your specimen types utilized for immunohistochemistry. So formalin-fixed paraffin-embedded tissues is a standard type of specimen that is used for IHC staining, as we all know. Tissues are fixed in formalin and then embedded with paraffin into blocks, and then finally slides are cut from those blocks to stain with the various assays. Other specimen types can be used for IHC staining, however. There must be policies and procedures in place in order to call out what that process would include. This means if you want to do immunohistochemistry staining on frozen section slides, slides that have been air dried, slides that have been made from a thin prep or SurePath instrument, and tissue that has been treated with chemicals to decalcify, you can. However, the way you go about doing this is likely going to require you to tweak the sort of normally accepted practices of performing IHC in order to get the same end result. These nuances must be determined during your validation and verification processes, which we will talk about later. The takeaway here is that it must be clear and formally stated what types of specimens your lab has validated with every IHC protocol, and then only those specimen types can be used for those protocols unless additional validations are performed. The next topic we're going to discuss is the quality management surrounding the instruments and equipment utilized to perform immunohistochemistry. We're first going to talk about function verification of the IHC staining instruments themselves. Function verification is defined as processes to verify that the instruments and equipment perform according to expectations for the intended use and within defined tolerance limits. So basically, action taken to answer the question, is the instrument operating like it should? Your plan for function verification should be imposed when you first implement the equipment in your department, anytime you move the equipment, and then anytime there is major maintenance performed on the equipment. These are events that could have a negative impact on the way the equipment functions and therefore require you to take steps to ensure appropriate and expected behavior after they occur. There should be policies and procedures that outline how to start the equipment, how to operate the equipment, and then how to shut it down should you need to. Your plan should include what kind of preventative maintenance is to be performed, and then finally guidance for troubleshooting the equipment and general repairs on that equipment. So as mentioned in the last slide, a key component of function verification is preventative maintenance. Your quality management plan for your IHC instruments must include all the things you do in order to keep your equipment in good shape and operating properly. Many of the tasks associated with preventative maintenance are general housekeeping items, such as cleaning up spills and washing out or cleaning containers or other ancillary components of the instrument. However, there are also more involved tasks that must be completed on a regular basis, such as maintenance like you would do on a car. This activity is usually performed less frequently, like annually or biannually, than our more housekeeping activities, which are likely performed daily or weekly. The manufacturer generally has recommendations in their operations manual of what actions need to be taken and at what intervals in order to properly maintain the equipment. All of these activities must be documented on a quality control form of sorts, because as we all know, if it isn't documented, we didn't do it. And then these quality control documents should be reviewed by a general supervisor on a regular basis to ensure the integrity and the completion of any necessary follow-up of the preventative maintenance being performed. In addition to the general documentation of all preventative maintenance, we also need to make sure that we note any issues or problems that might occur with the instrumentation. These can be noted on the same quality control form. Oftentimes, we engage outside services to either perform maintenance or to repair the instrument. When we do this, any documentation that is provided of this activity and what was done should be retained with the maintenance records of the equipment. And finally, corrective action should always be documented on the quality control forms when problems or issues arise. It is important to show either what was done to correct the problem or what steps were taken when the problem could not be immediately corrected and there was a need to ensure the continued integrity of some component of the testing. I want to quickly call out the importance of function verification on all the supporting equipment as well as the actual IHC equipment. I'm referring to equipment such as ovens if used for deparaffinization, any equipment used for antigen retrieval, refrigerators and freezers used to store various IHC supplies and reagents, and any other stainers that might be used as part of the process. It is important to have policies and procedures in place that outline the actions that need to be taken for these ancillary pieces of equipment as well. Successful assays rely on these pieces of equipment also functioning as they should. So the next topic we're going to discuss is general quality control and quality improvement when it comes to the process of immunohistochemistry. We're going to talk first about the buffers utilized for IHC. So the pH of the buffers utilized for IHC testing must be tested whenever a new batch is prepared or received, and they must also be monitored on a regular basis to ensure the pH remains within acceptable limits. As with everything else, this monitoring must be documented on some sort of quality control sheet or in a logbook to show that the testing was performed and that the results were all acceptable. We're going to talk a lot more specifically about controls used for IHC staining in subsequent slides, but I wanted to mention them briefly now in order to address the quality aspect. Controls that are used for testing must all be documented that they have been reviewed and are acceptable once all staining has been completed. This documentation must occur either prior to the result being rendered or at the same time. Either one is acceptable. Generally speaking, if the acceptability of the control is chosen to be documented at the time of result reporting, usually a comment is made that is included in the patient report stating as much. If the acceptability of a control is going to be documented prior to the result report being signed out, it must be maintained in a logbook, being very clear on the acceptability of each control. So there's kind of two ways of approaching this piece of the documentation. A lot of times you'll do it within the department and you can document it in a log, kind of at the time they come off the machine, someone takes a look at the slides and documents that acceptability, or, and this is probably the most frequent workflow that I see, is that the pathologist will do it at the time they actually sign out the report, and then just kind of in one fell swoop, they'll document all that in the report along with the result. All reagents must be included as part of the quality management program. This means that upon implementation, all of the manufacturer's instructions must be reviewed for all reagents to ensure that they are stored and handled appropriately. Additionally, reagents must all be labeled with an assurance that non-expired reagents are always in use. Reagents that are part of a kit must only be used within the same lot unless otherwise specified by the manufacturer. As part of any good quality improvement program, monitoring must occur on the performance of the testing. Turnaround time is often a good metric to keep track of and monitor so as to ensure that you are getting your IHC to your pathologist in a timely manner so that they can sign out their pathology report and get the information that the providers need in order to start a patient's treatment plan. Turnaround time could include parameters such as order to delivery of slides or time of delivery of IHC slides to the pathologist to sign out of the report. Staining quality is another good monitor to conduct so as to ensure you are putting out a good quality product. Monitoring could be geared to answer the following questions. Are your pathologists happy with the staining? Is it satisfactory? How many repeats have to be performed? Are controls of good quality? An important factor to keep track of from a financial aspect is the volume of IHC that are sent out, meaning at what volume does it make sense to send out versus when do you have enough volume that you should consider bringing it in-house. We all pay to have another lab do testing for us at some point or another, so perhaps at a point in time, it was cheaper to have the reference lab do the IHC for us because the volume was so low, but perhaps the volume has increased to a point where it is now cheaper for us to do it in-house than it is for us to pay a reference lab to do it for us. In our lab, this is something we regularly assess. It's also important to track how quickly we implement from the time a certain IHC is requested to be brought online. In my lab, we have a certain expectation for implementation so that patients and providers can take advantage of new antibodies that have come on the market. We strive to prioritize implementations and bring assays online in a timely manner. And then finally, the last monitor I'm going to suggest that might give you some areas to improve is that of the completeness of the reports. Do your result reports that contain immunohistochemistry outcomes include all of the necessary components? The next major topic we are going to talk about is immunoperoxidase antibody controls. There is a lot to understand on this topic, so I'm going to talk through each point. The first piece we will discuss is that surrounding positive controls. These are the controls that assess the performance of the primary antibody. This control is called positive because it contains the target antigen that the antibody will bind to and will therefore test positive. Positive controls should all be prepared and stained exactly the same way as the patient tissue so as to reduce any variables so that they can be exactly compared and the conclusion can be confidently obtained that the assay worked when positive staining is observed. As mentioned earlier, staining performance must be assessed and documented for all positive controls. Again, this can occur on a quality control record separate from the patient report, or it can occur on the patient report itself. Usually a comment such as controls are acceptable or controls reacted appropriately is acceptable. A bank of positive controls can be maintained if that logistically makes sense, as long as the controls have been documented as being tested for immunoreactivity. The preferred method of using a positive control is to place the section on the same slide as the patient's sample. However, you can also use a separate slide for the positive control. On the other hand, negative controls are also a key element of IHC staining. Negative controls are used to determine if non-specific staining is present, as well as determine the specificity of the antibody and to make sure there is no positive staining that is not expected. Like positive controls, they are stained the same way as the patient tissue, and the staining outcome must be recorded. They must be included for each antibody for each run. Generally speaking, biotin-free detection systems are used in the majority of labs, and these detection systems negate the need for negative reagent controls because you don't see a lot of background staining. So there are several types of negative controls. You have tissue microarrays, negative staining tissue elements in the positive control, or patient tissue that are used as a negative control, or a tissue control that stains negative. Whatever choice you utilize must just be specified in the IHC procedure. All three of these options are acceptable options to use for your negative tissue control. Probably one of the most important elements of an IHC quality program is the process for validating and verifying the performance of your test methods and antibodies. This is the next topic we're going to discuss. Just like any other test, when you start your implementation, you must make sure that you have read the manufacturer's instructions very carefully. These instructions must be followed in order to retain the status of the assay the way it was intended by the manufacturer. Any modification to the assay will force the test into the LDT or laboratory developed testing category, and with that will require different elements of compliance. The general steps of validation and verification include selecting the protocol, validation of the assay itself, and the implementation of the assay. The selection of the protocol includes determining all of the incubation times of the testing. This usually takes some back and forth between the technical and pathology teams in order to determine the best protocol for the tissue and antibody being validated. The actual validation of the assay starts after the protocol has been selected. Once the protocol has been selected, you then start the process of validating that particular protocol on a number of specimens to make sure that it is successful in achieving the outcome that is expected. The final step then is the actual implementation, where the assay is put into practice on patient tissue. So this is an example of a checklist that might be used in order to ensure that you are completing all necessary elements for a successful validation and verification. This kind of document can be used as evidence of compliance for external inspections. There are some other supporting documents that will go along with this checklist to validate the specific components of the process being performed. And we're going to talk about a couple of those supplemental documents in subsequent slides. But just to pause a little bit and talk a little bit about this checklist. So this is what we use in our lab, and it kind of is an ever-evolving document. But at the top, just to talk through it very quickly here, at the top we put some basic information about the antibody or the clone, laboratory department. We put a target date as far as when we feel like we would have this ready for in-house testing. We document our instrument, and then we document the patient testing location. And the reason for that is to sort of substantiate the part that I talked about earlier as far as when revalidation is necessary when an instrument changes location. So we decided to add on patient testing location so we can say, you know, this is done on the first floor lab, and if that lab is ever moved to the second floor or another spot, then that would then substantiate the fact that we did a revalidation because of the change of location. We do document whether it is an LDT or not. And then the kind of the middle section, that is the actual checklist then that we go through and then have supporting documents to document sort of the date completed that we document there on that right-hand column. So the first piece is the preliminary validation, which is where we do the protocol selection. The middle section is the actual test method validation, so that's where we do the comparison studies. And then the last part is actually the test implementation. And then we just have some items listed there that really, so that we don't forget to do them, in terms of policies being written and approved, any changes that need to be made to our LIS, any sort of communications that need to be done, and then just having appropriate SDS there, and then our final approvals, of course, by all of our CLIA roles, and then our medical director. So a key area to point out is that it is important to understand whether or not you are working with a predictive or a non-predictive marker. We're going to talk about both, but we're going to start with the non-predictive markers. Non-predictive markers are assays that are used for routine immunohistochemistry and are usually used to confirm or rule out a specific diagnosis. So examples of non-predictive markers are your IHC, such as vimentin, chromogranin, AE1, AE3, and synaptophysin. Really, this is the majority of your immunohistochemical assays. The majority of them fall into this category. So validation and verification must be performed for all non-predictive markers. This includes not only when you bring an antibody in for the first time, but also anytime you introduce a new clone. As with any new test, validation and verification must be performed and completed, which includes all review and sign-off prior to use on patient tissues. As mentioned earlier, validation and verification includes determining the titration for each antibody, as well as the protocols for the detection system itself, and any retrieval that needs to be performed on the tissue. Sensitivity and specificity of the antibody is also determined during this process. A successful validation and verification must be substantiated by at least 90% concordance. So this means that 90% of the tissue samples utilized during the process should show correct expected staining. At a minimum, 10 positive and 10 negative tissue samples should be used for your validation, and they should all be treated the exact same way in terms of processing and fixation. This eliminates any variables that might need to be considered later and fully supports a robust and effective validation. So in terms of concordance, this means that you should see at least 9 of each of these samples showing the expected staining pattern. If you don't see this, then you need to go back and assess your protocols and processes. So let's talk a little more specifically about the first step of implementing a new IHC assay. Determination of the protocol is the first step in performing a validation or verification of assay performance. Determining the protocol that you are going to use is essentially deciding what kind of incubation periods you are going to use for the primary antibody, labeled polymer, and secondary antibody if one is used. And then what the antigen retrieval method is going to look like if that's needed. An efficient way to approach this process includes first determining with a pathologist what tissue blocks should be used to run the various protocols on, so that you can decide which one is best. The tissue used should be a known positive control with internal negative controls. Once the tissue has been determined, various protocols should be run on it, including antigen retrieval in an organized fashion. One way to do this is to determine several protocols that you will run on every assay in order to determine the protocol, and start with the manufacturer recommended antigen retrieval method. The form example on the slide shows one way this can be done. So in this example, 6 slides of the same tissue are run with various incubation times that are shown in the blue box. So in that blue box, you can see there are 6 lines there, and in each, or 6 groupings, I guess, and in each grouping, you see 6 little boxes that have the 10, 10, 20, 20, etc. The instrument is programmed with incubation protocols at those 10, 10, 20, 20, 30, 30, and then 10, 15, 10, 20, 15, 20, and 30, 15, 30 minutes, each shown in the red box there. So just to explain that a little bit, the 10, 10, 20, 20, and the 30, 30 are our incubation times for, the first one is the antibody, and the second one is the labeled polymer. And then the series of 3, the 10, 15, 10, 20, 15, 20, and the 30, 15, 30 is the antibody, the labeled polymer, and then adding that secondary antibody. So for one slide, we pick one of those, and then we take six. We have 6 slides total, selecting one of each of those 6 for each slide, for each set of slides. Hopefully that makes sense. And then we select our antigen retrieval level. We identify that on this form under that antigen retrieval column. And then after the various protocols are run, the form and the stained slides are given to the pathologist for review, where they then indicate in the results column their impressions. And so then at that point, it's either decided to run a different combination of protocols and or antigen retrieval methods, or a protocol is actually selected. So we document that. We document at the top of the form, sort of, again, basic information. And then if we select a protocol, or if the pathologist is able to select a protocol after the first go through, they'll document that at the bottom of the form. So once a protocol has been determined, then the next step, which is the test method validation, can begin. There are various ways to validate an assay, and by this I mean methods that can be used to compare what you are seeing as you run the protocols that are new to your lab to known results of the tissue samples. First of these is morphologic or expected results. So this would include tissues that are of known origin that you know should stain positive or negative. Next of these is either comparison to an existing validated assay, either within the same lab or a different lab. So this would include using tissue that either your lab or a different lab has already stained, and compare that to the results of the staining performed with the new protocols in your lab. And finally, you can compare to other non-IHC tests or to PT samples. This is similar to the previous 2 items in that you might use PT tissue samples as your comparison, or other tests where you know the results, and those results can support the outcomes you are seeing with the IHC that you're validating. So the next step is the comparison study that needs to be completed with the protocol that was determined in that very first step. As mentioned earlier, for non-predictive markers, 10 positive control and 10 negative control slides need to be run in order to ensure that the protocol that was selected is adequate and functioning as it should. This slide presents an example to you of a form that can be used to document this comparison study. If during the study it is determined that the protocol does not prove to be specific or sensitive enough, a secondary validation will need to be performed. So this is the same step that would occur if after running the initial set of protocols, a protocol determination could not be made. These 2 aforementioned forms are examples of the supplemental documentation that you would use to support that initial implementation checklist in order to document the complete validation and verification process for a new IHC assay. So in addition to the validation processes that must be performed when your lab is bringing in a new assay, there are also verification requirements that must be executed on existing assays as, as new lots are received of both the antibody and the detection system. For these situations, lot-to-lot comparisons must be performed prior to using the detection system or antibody for any patient testing. This can adequately be completed using one positive control to determine adequacy of staining with these slides cut from the same block and then run on the old and new lots comparing outcomes. This slide gives you an example of how verification of detection systems can be documented as new lots of detection systems are received. Parallel staining is important to be performed in order to control for variables such as disparity in the lots of detection reagents or instrument function. As test kits are received, it is good practice to record information on the test kit in a logbook upon receipt. This could include recording the lot number, expiration date, and specifics on the reagents. Then, upon completion of your lot-to-lot comparison, you can then record the QC results and the date the QC was run. Similarly, the performance of new lots of primary antibody should be compared with old lots before being placed into service. Again, this parallel staining should be performed in order to control for variables such as disparity in the lots of antibodies or instrument function. Appropriate control tissues should be used to conduct the comparison, and slides should again be cut from the same control block. With a similar practice as the detection kits, as each antibody is received, it should be logged onto a document or a logbook identifying certain key pieces of information, such as the name, manufacturer, lot number, date received, expiration date, concentration, and the need for antigen retrieval. Then, upon completion of the parallel testing, the date QC was performed and the results of the QC should be recorded. This slide shows an example of a form that can be used in order to document lot-to-lot comparisons of an antibody. Other changes that require performance confirmation be conducted include antibody dilution, antibody vendor with the same clone, or the incubation or retrieval times with the same method. This is a simplified study that only needs to include 2 known positive and 2 known negative cases. A more involved study needs to be performed for more comprehensive changes in non-predictive assays. These are more extensive changes that could include change in antibody clone, introduction or change in antigen retrieval, detection system, instrumentation, fixative or processor change, and then relocation of equipment resulting in environmental changes or a change in water supply. These sorts of changes usually result in repeat of the assay validation study to ensure that the assays are functioning as they should be with these more significant changes. The second category of IHC markers are called predictive markers. These markers, as their name states, are used to predict responsiveness to a specific treatment independent of other histopathologic findings. Examples of these are HER2 and ER. The basic process for validation and verification of performance is the same for predictive as compared to non-predictive antibodies. It must be completed prior to any patient testing, with all of the same processing and fixation methods being utilized. For predictive markers, however, there is a requirement to test a minimum of 20 positive and 20 negative tissues for all FDA-approved testing. If the test is an LDT, or the laboratory developed test, or a modified FDA-approved test, the general recommendation is to use a larger number of test cases. And this is, again, just because it's not according to the FDA, or it doesn't have that FDA stamp of approval. Additionally, if a laboratory is running HER2 and ER LDTs, then a minimum of 40 positive and 40 negative tissues must be used for the validation process. The concordance expectation for predictive markers is 90%, while specific to ER, the concordance rate is 90% for positive results and 95% for negative results. And then, similar to non-predictive markers, any significant change to the assay requires revalidation and/or verification. So as discussed previously for non-predictive markers, that first step is that selection of the protocol. For predictive markers, this can be completed and documented using the exact same process. So again, this slide just shows the same type of form that we used for non-predictive antibodies in order to document the protocol selection process and approval for predictive antibodies. And then again, just like with the non-predictive markers, once that protocol has been selected, a comparison study needs to be performed. As indicated on this form and as discussed earlier, however, the number of cases used for these comparisons is larger. So it's the exact same form, it's just more line items to accommodate for the 40 slides. So as this audience is very well aware, the performance of the predictive markers are a little more significant and more regulated than the non-predictive markers. So as can be imagined, when something is more regulated, there are more standards that we need to ensure that we comply. We're going to review several of those requirements associated with breast carcinoma predictive markers with some ideas of how to demonstrate evidence of compliance. The first requirement is that there must be a comparison of patient results with published benchmarks, and this must be completed on an annual basis. So basically, we are trending the results we are seeing as a lab as compared to published metrics to ensure that we are in the ballpark as what the industry is seeing in terms of outcome. For ER-negative breast, specific to invasive breast carcinoma and DCIS, we should not exceed 30%. And then for HER2 positive breasts, labs should be seeing between 10 and 25%. And so like we do with other comparisons like these, such as with our GYN reporting rates, we must investigate if there was a large variance from that industry norm. So this slide demonstrates documentation of pathologist interobserver variability. Using PT samples, a formal assessment is performed of the interpretation by each pathologist, and then a concordance rate is calculated. So for each pathologist, a concordance rate is calculated for all of the cores they assess as compared to the other pathologists in the group. Corrective action is taken if a pathologist demonstrates less than a 95% concordance with the other pathologists. Corrective action will likely vary depending on frequency of subpar performance. For example, first-time unacceptable concordance might result in just a review of the slides, while consecutive unacceptable concordance rates might result in review of cases and perhaps additional education as determined by the medical director. This is something you should work with your pathology team in order to come up with a plan for steps to take when concordance falls below 95%. The next item requires labs to test at least one sample from a patient with invasive breast cancer tumor with both ER and HER2 if the tissue is available. Labs should just have a process in place in order to ensure that pathologists are ordering such IHC as they can and as the amount of sample allows. One of the more challenging requirements is that of fixation for specimens that could potentially be stained with HER2 and ER. HER2 and ER assays have very specific fixation requirements that must be closely followed. There could be negative impacts on a patient's therapeutic options if they are not. The compliance with these fixation requirements often takes a lot of education and cooperation with your surgical departments in order to ensure the guidelines are met and appropriate documentation is completed. Fixation requires the use of 10% neutral buffered formalin for between 6 and 72 hours with a volume of at least 10 times that of the specimen. The use of decal solution is generally not recommended. Immersion into the fixative must occur within an hour of the collection, and if there is going to be any delay in delivery, tumors should be bisected prior to immersion in the formalin so that the formalin can begin penetration. The time of the removal of the tissue and the time of the immersion into the formalin must be communicated. This is called the cold ischemia time. This is oftentimes accomplished via the specimen requisition so that the collection areas can just record it at the time of removal from the patient. If there are any other fixative utilized outside of 10% neutral buffered formalin, they must be part of the assay validation study. So the last nuance we are going to talk about in terms of predictive markers is decalcification. The decal of specimens to be stained with a predictive marker is generally not recommended. However, if it is necessary, the assay must have been validated using decalcified tissue. If it wasn't validated, there needs to be a disclaimer on the patient report stating that the assay was performed on tissue that was treated with a decalcifying agent and therefore may not be valid. Over the course of this presentation, I've mentioned that there are several things that need to be included in policies and procedures. So I wanted to bring all of those items to one slide to kind of summarize what policies and procedures, so that written documentation you need to have that needs to be on hand. General IHC procedures should be written. By this I mean policies related to each antibody assay that you performed. How you do this is really entirely up to you, as long as they are done in such a way so as to be useful to your staff. Many facilities prepare one document for every IHC they perform, outlining all the necessary components, and then group some of the more general items into their own policy. Several of the items that must be clearly outlined in your policy and procedures is the acceptable pH range of any buffers that are used in the assay, any specimen modifications that might be in place, the kind of positive control used that is used and how it's used, the manner in which internal positive controls are used, if they are in fact utilized, the kind of negative control tissue that is used and how it's used, the use of negative reagent controls if you use them, what the process is for validation and verification of new antibodies, how you perform lot-to-lot comparisons for both antibodies and the detection systems, and then how you correlate your IHC results. So bottom line is that the specific policies and procedures that must be in place must include those for your predictive markers specific to many of the things we just talked about, but also to include items specific to predictive markers such as the scoring and reporting of results, guidelines for utilization, fixation requirements, and how you perform inter-observer variability. And then you must also have those policies and procedures that outline all of the non-predictive markers and then function and verification procedures for your IHC and ancillary equipment. Proficiency testing and alternative assessment is a key component of the quality improvement program for predictive markers, so I wanted to touch upon that quickly. Specific to CAP inspection, CAP requires that if predictive markers are performed in your laboratory, you must participate in proficiency testing or alternative performance assessments. If you only interpret HER2 and ER breast markers, you must still participate in the CAP PT program, just a little bit differently than you would if you were actually performing it. So IHC slides for those sorts of facilities may be sent to another facility for staining only and then interpreted at that originating laboratory. HER2 PT is method specific and something must be done for each method, whether it is a formal PT or an alternative assessment. And then if there is no formal PT for a particular predictive marker, then a semi-annual alternative performance assessment must be performed. This is the one area in AP that really mimics the clinical side in terms of PT and what the requirements are from a CAP standpoint. The last topic I want to review, which kind of brings everything full circle, is the final result reporting that is produced, which includes all of the patient results of the IHC testing that is performed. There are a number of components associated with this testing that must be present on the patient report. Result reports are the products, if you will, of all of the efforts within the laboratory. It is important that our end product is complete and contains all required elements. IHC should be reflected on the patient report in a clear and concise manner. Results should be correlated, so the IHC results and how they relate to the morphologic results as seen in the H&E slides should be indicated somewhere on the report. And then if you decided that you were going to reflect the performance assessment of the controls in the patient report, you must also make sure that these statements are included. Some antibodies are considered class 1 ASRs, and ASR stands for analyte-specific reagents, and these are indicated in the manufacturer's instructions if this is their status. When these types of antibodies are used in IHC assays, a disclaimer must be included in the patient's report indicating that the test was essentially developed and validated by the laboratory. It must be clear on the report that the test is not approved or cleared by the FDA. And then finally, for those patient reports that include the results of predictive markers, there are additional elements that must be present. For breast tumors where fixation requirements had to be met, those specimen fixation and processing points must be outlined. Additionally, the antibody clone and form of detection utilized, along with the scoring system that was used, must be included. Finally, the interpretation must be in the correct structure and format following the predefined criteria for that particular predictive marker. So with that, I will conclude by pointing out that IHC testing has a very big impact on the categorization of patient specimens, and these outcomes are instrumental in the determination of patient treatment options in many cases. It is so very important to have a well-developed and run IHC department because of the positive impact all of this has on patient safety and outcome. I hope that you found the presentation worthwhile and valuable. And if you have any questions, please feel free to contact me at my email address, and I will be happy to either answer any questions or share any information that I have.